Thank you very much. I thank to organizers, Professor Daniele Tonietto and all my colleagues from EuroCovCat group for the invitation. It's a pleasure and an honor for me to be here. I've been asked to talk about the vitreous loss during phacoemulsification, which is a complication that you don't really want to see during your cataract surgery, but still it happens. And there are two main mechanisms of vitreous loss during cataract surgery. The posterior capsule break or rupture, PCR, which can happen in almost any time of the surgery, unfortunately. And the second one is the zonular rupture, which can be more or less extended. In both cases, anterior vitrectomy is mandatory, and this is only one step of the surgery. You need to go to finalize the surgery as good as you can and to implant the proper intraocular lens given the new situation. The sooner the vitreous loss appears during the phacoemulsification, the more complicated it is to solve it, because you still have there, for example, at the beginning of the surgery, you still have their nucleus. Sometimes maybe the whole nucleus, or maybe sometimes only pieces. You still have cortex, and you have to deal with it. You have to clean it as much as possible completely. And of course, the vitreous and lens material should be cleaned, I would say separately, avoiding pulling the vitreous. The goals are to limit the damage, avoid enlarging the break, to finish the phacoemulsification and complete the lens removal, as I just said, and to finish the phacoemulsification and to avoid nucleus pieces to fall in the posterior cavity, and to perform such an anterior vitrectomy technique, that you can avoid pulling the vitreous, because this can lead to further later complications such as cystae, macular edema, and even retinal detachment. There are a few principles of anterior vitrectomy technique, in my opinion. You can do it either by anterior chamber approach or by pars plana approach, but you need to create best visualization conditions. Sometimes you need to enlarge the pupil with devices if it is necessary. You can use also triamcinolone for better visualization if needed. You need to keep a closed system. For example, you may even need to suture the main incision, even if it is quite small, and to use the smaller incision, the side ports, for the cutter probe. And this is because you don't want to, if you would use the main incision, which is larger, you have the more possibility to aspirate the vitreous and to even create worse this vitreous prolapse. The dry vitrectomy is a good idea, in my opinion, under viscoelastic, but some surgeons prefer to perform under BSS infusion in the anterior chamber. Sometimes you can do the infusion in the pars plana and perform anterior vitrectomy via the side ports. And very important is to use the machine capabilities, to change the vitrectomy mode in IA cut mode, as you will see in my first video, and to use higher frequency cutter for vitreous and lower for thick cortex. In the last 5 years, I became also a VR surgeon, but for the anterior segment surgeons, I strongly recommend to have, if they are not used with the pars plana approach, to use the anterior chamber approach, which can be very good as well if you respect some conditions, you will see later, and to use dry vitrectomy. I'm a fan of dry vitrectomy done under viscoelastic. So let's see the first video. This is, I finished the phacoemulsification. I just have only cortex, and I notice a relatively small peripheral break in the posterior chamber. The first thing is to inject in that place OVD and to perform vitrectomy there, and then I take care of the cortex away from the, let's say, the sick area. And this is because you don't want to deal from the beginning with the vitreous. And look in the upper part of the video, you can see I am now in IA cut mode, then in vitreous mode. You use IA cut mode when you want to pull the cortex from the equator and then bring it in front, in the middle of the anterior chamber, and then use cutter mode. So you can cut the vitreous together or the cortex together with the vitreous. Again, IA mode, to bring the pieces from the peripheral equator to the center, and then again anterior vitrectomy mode. In this way you will avoid pulling the vitreous when you pull the cortex. In the same time, you don't want to use cutter when you are in the periphery, because there's a danger to damage the anterior capsule, which is very important to create your support, like in my case, to implant a 3 pieces IOL in the sulcus with optic capture. So again, master the foot pedal and the 2 modes, IA cut mode and vitrectomy mode, when you deal with remnants of cortex or even with nucleus species. And this is another case done by a colleague of me. This is a polar posterior cataract over which it developed an intumescent anterior cataract. The capsulorhexis was fine, but the posterior capsule broke in a specific design, like almost all of the polar cataracts broke. The surgeon preferred to use not dry vitrectomy, but vitrectomy under BSS infusion in the anterior chamber, as you see in the right hand side of the video. But he completed, again using the binom IA cut and vitrectomy mode, he completed successfully the cortex aspiration, and he implanted the 3 pieces IOL in the sulcus. He prefers not to use in this case, the optic capture. What about the second mechanism of vitreous loss during the phacoemulsification? This is the second mechanism is zonular dialysis. This is a patient with small pupil, but not necessarily a pseudoexfoliative syndrome. I dilated the pupil because it was too small, and I noticed at the end of the phacoemulsification this zonular dehiscence. Luckily, it is not too large. It is highlighted by the red arrow. And after I finish, I push it. First, when you see this zonular dehiscence, first thing is to push with the OVD the area, which is dehiscent, towards the periphery to stabilize the bag, implant or inject as much as possible OVD to create space to work further. And what is the working further is to finish the cortex, implant a CTR. You can choose, like Isabel showed, you can choose to put it earlier or later. In this case, because the dialysis was not very large, I prefer to finish the cortex removal because it's easier without a CTR, and to implant a CTR afterwards. It stabilizes my bag, and then I implanted safely an IOL in the bag. At the end, maybe you notice, I had an irregular pupil at the, let's say, 2 o'clock hour. And when you have this sign, you can either use triamcinolone to be sure, or you can use Myocol to constrict the pupil, or with a simple gesture like I did with a spatula, you just try to pull to see if there are some vitreous strands, and there was a vitreous strands which deformed my pupil. I put it in the center and cut it with a vitrectomy. At the end, you need to have a round pupil and with a round capsulorhexis and the well-centered IOL in the back. And this is the last case, vitreous loss due to zonular dialysis, again at the very end of the surgery. So I implanted safely under OVD an IOL, a soft and nice IOL in the bag, and look what happened at the very end of the surgery. It's very frustrating. The vitreous is getting out through the main incision. I just clean a bit that area, but again, don't forget to perform your anterior vitrectomy via side port, because thus you avoid pulling more of the vitreous. Again, the bag is completely clean, of course, because I'm at the end of the surgery. I inject CTR, again under plenty of OVD, because you don't need to pull more while injecting CTR. You don't need to pull and to stress more the zonules. And then the IOL, and then wash the OVD, of course, and at the end you have a nice round pupil and a well-centered IOL. This is the last video, is just to show how you can use the triamcinolone in the cataract surgery. This was a case with a post-traumatic cataract, old patient, post-traumatic subluxated lens. I withdraw the cataract by intracapsular technique. You see a large incision. I close the incision just to have a closed anterior chamber. I sutured the incision and triamcinolone, and now you completely, as you see, I'm with my vitrectomy probe, not through the main incision but through the paracentesis. And you do this until you perform vitrectomy, until you see that there is no white tissue, white triamcinolone in the anterior chamber. Eventually, this patient had a Creos type IOL sutured the sclera with Gore-Tex suture. So as conclusion, anterior segment surgeon can control and master the cataract surgeries complicated with vitreous loss, produced either by PCR or by zonular dehiscence, if he or she respects some general rules, mandatory steps for a complete and correct anterior vitrectomy. The main goals are to limit the vitreous loss as much as possible and to prevent further complications like drop nucleus or damaging other ocular tissues, to clean completely anterior chamber, the capsular bag, no vitreous, no lens material on your bag and in your anterior chamber, and to assure a proper insertion in a proper position of a suitable IOL, which might be different of the one that you planned initially, because now it should be according to the new local environment. Thank you for your attention.